Assalamu alaikum. Our lecture today is about endometrial cancer. The malignant disease of the uterus, we call it endometrial carcinoma, has good prognosis in which 5-year survival rate is 60%. If one asks you what is the most common malignancy of female genital tract, the answer is breast cancers. Okay? And what the most common tumor of the genital tract is the CA cervix. So the only tumor that have good prognosis is endometrial cancer. Why? Because the 5-year survival rate is very high, 60%. What is the epidemiology? The median age of presentation is 60 years old, i.e., this is the age of menopause. 75 to 80% of cases are post-menopause, as we mentioned, but there is a 3 to 5% of cases are premenopausal, less than 40 years old. That's why any patient presented with post-menopausal bleeding, it is an endometrial cancer until improved otherwise. Etiology. What is the etiological factor? What is the risk factor? Who's the patient who are liable for develop endometrial cancer more than other one? First of all, X is an opposed estrogen stimulation of the endometrium. What is meaning by an opposed estrogen? Which is mean there is no progesterone. Premenopausal female which have high incidence of anovulation due to PCOS. As we know, PCOS there is no ovulation, so there is no progesterone, and the progesterone this is the hormone that anabolizes the action of the estrogen. Obesity, very important, because the main circulating estrogen in postmenopausal women is derived from aromatization of the peripheral androgen in fat and muscle, and also reduce sex hormone binding globulin. So that's why if patient come to you postmenopausal, obese, especially morbid obesity, and she have vaginal bleeding, you have to think by endometrial cancer, because those ladies more liable for developing it, as the cause we mentioned. Disturbed carbohydrate intolerance, but in this cause is unclear here. In postmenopausal women with diabetes have increased estrogen independent of body weight. يعني مثلا حتى لو كانت مريضة low weight بس يصير عندها شنو disturbs بالcarbohydrate intolerance independent of body weight. So there may have altered estrogen metabolism independent of the effect of راح تتغير طريقة الأيض الاستروجين، ما لها علاقة بكمية الوزن الزائد. Women with personal history of breast or colonic cancer, they are risk. Women who take tamoxifen are exposed to risk of estrogenic type effect on the uterus. The ovarian tumor, like granulosa thick cell tumor, in which there is 10% endometrial cancer and 50% endometrial hyperplasia. Family history of the breast, colon, endometrial cancer. Nilibara, also this is the risk. And the last one, early menarche and late menopause. So this is are the 10 risk factor, etiological factor for developing of endometrial cancer. Now we are going to talk about endometrial hyperplasia and what we are going to deal with this. This partly because this lesion cannot be identified clinically and their detection is dependent on blind biopsy. Okay, so this is need an investigation. The pathology. The first one we call it simple hyperplasia. The other name cystic hyperplasia. It's characterized by increased number of glands that are dilated with irregular outline, some degree of crowding, تزاحم, reducing amount of stroma, but no cytological tibia. Still, the cells preserve their normal numbers of chromosome. Complex hyperplasia, the other name adenomatous hyperplasia. The glands have irregular outline, show marked structural complexity. The glands show back to back, يعني تراصف, crowding with little stroma. But still there is also no cellular atypia. The third one, serious one, we call it atypical hyperplasia. The glands show nuclear atypia and abnormal mitosis figures and severe structural abnormality. This is the most serious one. Etiology, why? The obvious predisposing cause may found, but the most common cause is excess estrogen, the same cause as endometrial cancer, and opposed by progesterone, either arising from anovulatory cycles or estrogen secreting tumor and tamoxifen effect. This is the etiology regarding endometrial hyperplasia. In natural history, how the disease is progress, يعني كيف تتقدم الحالة في حالة الهايبربليزيا. Cystic hyperplasia اللي هي symbol 1 is common in both menopausal women and an ovulatory teenager. It is rarely seen with endometrial cancer. The risk of progression is very low, 0.5 to 1%. Adenomatous hyperplasia, the risk of progression will be increased to 3 to 4%. Atypical hyperplasia, CA may exist, يعني احتمال عندها cancer in 20 to 50% of cases or concurrent endometrioid ovarian carcinoma. What is the clinical feature? How is the patient presented to you? In premenopause women, they present with abnormal bleeding. In simple hyperplasia, the patient presents with infrequent heavy period, but the complex and atypical hyperplasia does not give characteristic pattern of bleeding, i.e. abnormal bleeding. The largest group is postmenopausal and perimenopausal. Okay? إذن بالنسبة للإندومتريال هايبوبليجيا وحتى الإندومتريال كانسر فد unscheduled bleeding، يعني نزف غير مبرمج، يعني نزف يكون طلع عن المألوف للفيميال سايكل. Okay? How you are going to investigate? You have to do biopsy, hysteroscope, ultrasound, examination under anesthesia or dilatation and curettage. How you are going to treat? First of all, you have to treat the risk factor. Discontinue estrogen treatment and remove the estrogen secreting tumor. This is one. In cases of cystic hyperplasia, the simple one does not require special follow-up and may manage on the basis of subsequent symptoms. يعني إذا سوينا لها biopsy والمريضة صارت يعني طلع التقرير cystic hyperplasia فتبقى على الفولو-up إذا زاد البليدنج وإذا قل البليدنج on subsequent system. بالادينوماتوس hyperplasia اللي هي الكومبلكس have low risk of progression to CA يعني اللي قلنا 3 to 4%. So there is no indication for hysterectomy or progesterone therapy. Also, a subsequent management depends on further symptoms. تعتمد ايش راح يصير المريضة بعدين. لكن بالatypical hyperplasia the treatment is total abdominal hysterectomy, bilateral salpingo or oophorectomy because of high risk of coexisting CA. Younger women who wish to preserve fertility can manage by high dose of progesterone, 20 milligram per day. May stop after 8 to 12 weeks. Long-term follow-up is required because of risk of carcinoma, those patients who want to preserve their fertility, because the risk of carcinoma is high. After we talk about the endometrial hyperplasia, now let me return back to endometrial carcinoma and to know the pathology. What is the different type? Endometrial adenocarcinoma, adenosquamous carcinoma, papillary serous carcinoma, clear cell carcinoma, وendometrial stromal sarcoma. Malignant mixed Mullerian tumors. This is the different pathological types of endometrial cancer. How is the cancer spread? What is the method of spreading of the cancer? Endometrial carcinoma invade to myometrium, sometimes extend over the endometrium before penetrating the myometrium. Also invade to the lymph node, اللي هي البارا-aortic lymph node, spread to the cervix by extension, but infiltration through the lymph and cervical stroma is more common. Direct infiltration into parameterium is uncommon, except when the cervix is involved. Spread to ovary is common. Transperitoneal spread spread when myometrial invasion reach the serosa or via the fallopian tube. Staging, very important. You have to know the staging of each cancer, whether endometrial cancer, cervical cancer, ovarian cancer, very important. Here in stage 1, we divide to A, B, C. 1A, tumor limited to the endometrium. If it is invade less than half of myometrium, we call it B. Invade more than half of myometrium, we call it C. So all this is stage 1, A, B, C. If the tumor is transverse to the cervix, so we call it stage 2. If it is involved just a gland, we call it A. If it is involved stroma, we call it stage 2B. Okay, stage 3, here the tumor goes to the serosa or adnexia, and there is positive peritoneal cytology, we call it stage 3A. If the vagina is involved, we call it stage 3B. If there is metastasis to the lymph node, whether pelvic or para-aortic, we call it stage 3C. Stage 4 is very simple. It is يعني تقريبا تشمل جميع الكانسر. Stage 4A إنه هو involve bladder and bowel. وstage 4B هي distance metastasis including intra-abdominal or inguinal lymph nodes. So staging system is very important to endometrial cancer because it is determine the type of treatment. A clinical feature نرجع ونقول abnormal bleeding, discharge or pain or abnormal screening test. Postmenopausal bleeding because 75 to 80% of disease in this age group. Vaginal spotting, this should not relate to atrophic vaginalis unless investigation is normal. يعني كأي مريضة تجينا نرجع نقول postmenopausal bleeding is an endometrial cancer حتى يثبت العكس. Cervical smear endometrial biopsy should be performed in all cases. Diagnostic curettage in patients with biometra reveal cancer in 5% of cases. Pain due to the nerve compression or constant dull pain or cramping due to the biometra. In premenopausal women, there is irregular bleeding or heavy but regular period. يعني any unscheduled bleeding. How we are going to examine this lady. What is the importance of examination in patients with endometrial cancer? You may see a large lymph node in the groin or supraclavicular lymph node. Metastatic focus in the vagina, commonly on the anterior wall. So, if one asks you what is the differential diagnosis of the mass of the vagina, 3 differential diagnoses. Could be endometriotic mass, could be choriocarcinoma, and could be endometrial cancer. This is the differential diagnosis of focus or mass in the vagina. The uterus enlarged or separate to adnexia or parameterium. Breast cancer may present with uterine or ovarian separate. How you are going to investigate? You have to do an investigation outpatient or inpatient. Outpatient, endometrial biopsy, you have to do vaginal and abdominal ultrasound, hysteroscope, and even colposcope. Inpatient, examination under anesthesia, fractional curettage, hysteroscope, other general tests, as we know, chest X-ray to exclude metastases, intravenous urogram, complete blood picture, renal function test, magnetic resonance imaging, and serum electrolytes. هسه راح نجي نحكي عن التريتمنت اللي هي very important. بالستيج 1 as we mentioned, stage 1 هنا الكانسر is involved to the uterus. يعني إذا وصل مرحلة السيرفكس حفظوها إنه معناته stage 2. Surgery: total abdominal hysterectomy, bilateral salpingo-oophorectomy. And certain important point you have to think in your mind. The adnexia should be removed. يعني لازم احنا نشيل الاوفري والتيوبس والادنكسيا كلها. Why? The adnexia should be removed because of the risk of subclinical metastatic tumor rather than to eliminate any hormonal influence. يعني أنا ما أشيلها على مود أتخلص من الأستروجين والبروجستيرون، وإنما لأن احتمال أكو subclinical that cannot be recognized. Removal of vaginal cuff not reduce the recurrence or improve survival. يعني it is up to you. Occlusion of the cervix and fallopian tube to prevent intraoperative spillage of a tumor are unnecessary. It is not necessary. The role of lymphadenectomy is to identify those women who need what without nodal disease, who not need radiotherapy to avoid the risk of complication, which is mean you have to sample lymph node. A pelvic lymph node involvement, so dissection is performed. This is in stage 1A. Radiotherapy: a brachytherapy to vaginal vault or teletherapy to the whole pelvis. Post-operative radiotherapy to vault reduce recurrent and mortality rates. Teletherapy used in women whose poor prognostic factor اللي هي شنو؟ invasion more than halfway يعني معناتها stage 1C, the myometrium or high grade tumor and large tumor. Now stage 2, which is mean involve the cervix. If it is the gland A, if it is the stroma B. Here, the treatment depends on microscopic and macroscopic involvement of the cervix. If the disease is occult in the cervix, so the treatment is the same as stage 1 with the same prognosis. The need for radiotherapy is dependent on the depth of myometrial invasion and tumor grade. Prognosis not improved by post-operative teletherapy, but complication increase. If the disease is obvious in the cervix, so prognosis is worse. The 5-year survival rate is 30 to 60%. Here, the treatment is by total abdominal hysterectomy, bilateral salpingo-oophorectomy, and bilateral pelvic lymphadenectomy, and para-aortic lymph node sampling. Stage 3 هاي قلنا إذا صار عندنا involvement of adnexia, involvement of the peritoneal. Here, CT scan should be performed if the disease is confirmed in the pelvis, so the radiotherapy is the treatment of choice. If the disease in the adnexia, laparotomy should be performed to see the extension of disease and to remove as much as possible for tumor. يعني تشيل اللي تقدر عليه إذا واصل هاي المرحلة للتيومر. Stage 4, هنا the aim is for symptom control and local tumor control, so radiotherapy, cytotoxic and hormone treatment may be required. Recurrent disease. They found that 70% of recurrence following primary treatment occur within the first 2 to 3 years. Early recurrence carry poor prognosis. Adult recurrence is more common in the non-irradiated patient. If there is single site of metastasis, فتستخدم أنت radiotherapy. The cure rate 30 to 60% of recurrence, and the radiotherapy is of value to relieve pain, discomfort due to the bone and nodal disease. Here, the progesterone treatment. The response rate is 15 to 20 with a grade 1 tumor than a grade 3 tumor. Medroxyprogesterone acetate oral 200 mg, very high dose, 2 or 3 times per day. Cytotoxic treatment is less attractive option because the patient is old, medically unfit, and the drugs is adriamycin, cisplatin, cyclophosphamide. Hereafter, this is the important point regarding the endometrial cancers, which is involve the endometrium of the uterus. Now we talk about the myometrium. The cancer of the myometrium, we call it uterine sarcoma. طبعا الكرايتيريا مالته بنشوف الساركوما highly malignant tumor. The incidence is rare, 3 to 5%. It is common in black women and those with history of previous pelvic irradiation. عندنا 2 type اللي هو endometrial stromal sarcoma, low grade. It arises from stroma and from adenomyosis and endometriosis. It is look like a fibroid, but in 20 to 30% of cases, spread into the broad or cardinal ligament, adnexia, and other abdominal organ. What is the treatment? TIH, total abdominal hysterectomy and bilateral salpingo-oophorectomy with wide excision of parameteria. The recurrence is high as 50% and can be detected by carcinoma 125 markers. The high grade, it is highly aggressive tumor, occur after the menopause and present with postmenopausal bleeding or discharge and pain. Again, the treatment is total abdominal hysterectomy and bilateral salpingo-oophorectomy زائد radiotherapy. Now, other type of a tumor, we call it malignant mixed Mullerian tumor. It is composed from malignant gland and malignant stroma. It is called carcinosarcoma, يعني involve carcinoma على الابيثيليوم وساركوما على التشوز connective tissue. If homologous elements are found, and called mixed mesodermal tumor if heterologous elements are found. It is present with abnormal bleeding, pain and mass. The average age is 60 years and is highly aggressive tumor, as endometrial carcinoma with radiotherapy. Myometrial tumor. Leiomyosarcoma look like fibroid, but the cut surface yellowish, more than a fibroid, with areas of hemorrhage and necrosis. The 5 to 10% of leiomyosarcoma that arise from the fibroid have better prognosis than those arise directly from normal myometrium. يعني الساركوما اللي تطلع من existing fibroid, it is better prognosis than that arise from normal myometrium. Treatment, again, total abdominal hysterectomy and bilateral salpingo-oophorectomy. This picture shows you the endometrial cancer, looking abnormal growth inside the uterus. Another picture that shows you endometrial cancers. Here, stage 3B endometrial cancer look to the spread up to the tumor, up to the parameteria. And this is another picture that shows you the uterus that fill with cancer cell. This is the picture show you abnormal cancer. And also this is another picture that show you specimen from the uterus who have malignancy. And this is a laparoscopic view that show you how the cancer is spread all over the pelvis. And this is the different radiological finding in patient with cancer. First one, this is an ultrasound. The second, this is a laparoscopic view. And the third one, this is the MRI scan. This is the histopathology. Look to the crowding, look to the abnormal specimen. This is the different tumor cell and the myometrium. And thank you very much.